Welcome to MRCS and Beyond. This is the Viva Ready series, where we tackle high-yield OSCE topics in detail. If you haven't already, don't forget to follow and subscribe to keep up to date with new videos, and do check the link in the description for our complete MRCS podcast series and accompanying notes. Let's get into it. So here's our roadmap for Part 2, 4 color-coded blocks. Liver, lobes, Cantley's line, and the 25-75 supply rule. Gallbladder, Collat's triangle, and the biliary tree. Pancreas, its parts, ducts, supply, and development, and then spleen, esophagus, stomach, and the duodenum. These are the structures that come up most often in abdominal vivas and the ones with the most named landmarks you need to spit out under pressure. 6 topics: liver, lobes, Cantley's line, ligaments, and the 25-75 rule for hepatic blood supply. Gallbladder, Collat's triangle, cystic and hepatic ducts. Pancreas, parts, ducts, blood supply, and embryological development. Spleen, the rule of odd numbers and splenectomy risks. Esophagus and stomach, constrictions, curvatures, and supply. And the duodenum, 4 parts, and the papilla of Vater. Let's start at the top, the liver. A quick refresher before we get into the parenchyma, because the left renal vein is the most exam-friendly vein in the abdomen. It's longer than the right because it has to cross the midline anterior to the aorta to reach the IVC on the right. On its way, it passes through a tight gap between the aorta posteriorly and the SMA anteriorly. That's the nutcracker. It receives 3 named tributaries: the left gonadal, left suprarenal, and left inferior phrenic veins before draining into the IVC. Now, nutcracker syndrome. Compression of the left renal vein in that aortomesenteric angle raises its pressure. Blood backs up into the left gonadal vein, and that's why you classically get a left-sided varicocele in men and pelvic congestion in women. Hematuria and flank pain are the textbook presenting features. And don't confuse it with SMA syndrome. That's compression of D3 in the same angle, not the renal vein. 2 syndromes, 1 piece of anatomy. The liver has 2 different ways of being divided, anatomical and functional, and the Viva loves the difference. Anatomical lobes are split externally by the falciform ligament, so you see a right and a left lobe on the surface. But functionally, the liver is split by Cantley's line, an imaginary line running from the gallbladder fossa to the IVC. And this is the line surgeons actually cut along, because it follows the territory of the middle hepatic vein and the right and left branches of the portal vein. The big point, the caudate lobe, segment 1, and the quadrate lobe, segment 4, sit anatomically on the right of the falciform, but functionally they belong to the left liver. Then we have Cuynod's 8 segments. Each segment has its own portal triad, branch of portal vein, hepatic artery, and bile duct, and its own venous drainage. That's what makes segmental resections possible. Segment I is the caudate, sitting behind everything else, and unusually, it drains directly into the IVC. Segments 2 and 3 are left lateral. Segments 4A and 4B are the left medial, the quadrate. And segments 5 through 8 are the right lobe, numbered clockwise starting from the antero-inferior corner. So a right hepatectomy removes segments 5 through 8. That's what you say if asked. The porta hepatis is the door into the liver, and 3 structures come through it. From front to back, the common bile duct, which sits anterolateral on the right, the hepatic artery proper, anteromedial on the left, and the portal vein, which lies posterior to both. Now, the 25-75 rule, beautiful Viva fact. The liver receives dual blood supply. The hepatic artery delivers about 25% of blood flow, and the portal vein delivers about 75%. But because portal blood is partially deoxygenated and arterial blood is fully oxygenated, each contributes roughly 50% of the oxygen the liver receives. Peritoneal ligaments to know. The falciform, anterior, contains the ligamentum teres, which is the obliterated left umbilical vein. The coronary and triangular ligaments form the superior reflections, and between them sits the bare area of the liver, in direct contact with the diaphragm. And the lesser omentum, that's the hepatogastric and hepatoduodenal ligaments, its free edge contains the porta hepatis itself. So, if you're ever told to clamp the structures going into the liver, Pringle's maneuver, that's the free edge of the lesser omentum you're squeezing. Kalot's triangle, also called the cystohepatic triangle, is the single most important triangle in the MRCS abdomen viva. Know its borders cold. Medially, the common hepatic duct. Inferiorly, the cystic duct. Superiorly, the inferior surface of the liver. Contents: the cystic artery, which is typically a branch of the right hepatic, Lund's lymph node, the cystic lymph node, and occasionally an aberrant right hepatic artery. Now, the biliary tree from top to bottom. The right and left hepatic ducts unite to form the common hepatic duct. The common hepatic duct plus the cystic duct gives the common bile duct, the CBD. The CBD then passes posterior to D1, then through the head of the pancreas, joins the main pancreatic duct, and empties at the major duodenal papilla in D2, via the ampulla of Vater surrounded by the sphincter of Oddi. One surgical pearl, the critical view of safety during a lap chole. Before you clip anything, you should see only two structures entering the gallbladder: the cystic duct and the cystic artery, with the hepatocystic triangle dissected clear. That's how you avoid a bile duct injury. The pancreas is a retroperitoneal organ lying transversely from the C-loop of the duodenum to the splenic hilum, across L1 to L2. 5 parts. Head sits within the C-loop of the duodenum, and the CBD passes through it to reach the papilla. Uncinate process, a posterior hook off the head, and the SMA and SMV emerge anterior to it. Neck sits anterior to the SMV and the portal vein, and lies on the transpyloric plane at L1. Body crosses the aorta, the left kidney, and the left adrenal. Tail extends into the splenorenal ligament and touches the splenic hilum, which is exactly why the tail of the pancreas is at risk during splenectomy. Damage it, and you get a pancreatic leak. So when an examiner asks for the relations of the pancreas, go bit by bit. Head in the C-loop, uncinate behind the SMA, neck on the transpyloric plane, body crossing the great vessels, tail kissing the spleen. 2 ducts. The main pancreatic duct, the duct of Wirsung, joins the CBD, and they enter the duodenum together at the ampulla of Vater, on the major papilla in D2. The accessory duct, the duct of Santorini, drains the head and opens separately at the minor duodenal papilla slightly proximal. The sphincter of Oddi controls secretion into the duodenum, and spasm of Oddi causes biliary colic. One developmental fact to know: pancreas divisum, failure of the 2 ducts to fuse, is the commonest congenital pancreatic anomaly. Most cases are asymptomatic, but it can predispose to recurrent pancreatitis. Endocrine function, the islets of Langerhans, and you need to know the cell types. Alpha cells secrete glucagon, beta cells secrete insulin, and they make up the majority of islet cells. Delta cells secrete somatostatin, which inhibits both glucagon and insulin. And PP cells secrete pancreatic polypeptide. The exocrine acyni sit around the islets and secrete trypsinogen,
lipase, and amylase into the main duct. Endocrine and exocrine, one organ, two systems.
Blood supply is the foregut-midgut watershed. The head of the pancreas is supplied by the superior pancreatico-duodenal artery from the gastroduodenal, which comes off the celiac, and by the inferior pancreatico-duodenal artery from the SMA. The two anastomose around the head, and that anastomosis is the foregut-midgut watershed. The neck, body, and tail are supplied by branches of the splenic artery, including the pancreatica magna and the dorsal pancreatic. Venous drainage parallels the arterial supply into the SMV and splenic vein, which form the portal vein. Embryology, and this comes up. The pancreas develops from two buds of foregut endoderm, a ventral bud and a dorsal bud. The ventral bud rotates with the duodenum and fuses behind it to form the head and uncinate process. The dorsal bud forms the body, tail, and accessory duct. An annular pancreas occurs when the ventral bud, or a bifid variant of it, encircles the duodenum, leading to duodenal obstruction in neonates. Rare, but classically asked.
The spleen is an intraperitoneal organ in the left hypochondrium, lying against ribs 9, 10, and 11 posterior to the mid-axillary line. And the easiest way to remember its dimensions is the rule of odd numbers: 1, 3, 5, 7 to 11. 1 inch thick, 3 inches wide, 5 inches long. It weighs about 7 ounces, and it sits under ribs 9 to 11. It has two surfaces, diaphragmatic and visceral. Blood supply: the splenic artery from the celiac, tortuous along the upper border of the pancreas, and the splenic vein which runs behind the pancreas. Two key ligaments. The gastrosplenic contains the short gastric vessels and the left gastroepiploic. The splenorenal contains the splenic vessels and the tail of the pancreas. So when you mobilize the spleen for a splenectomy, you ligate both of those ligaments, and you protect the tail of the pancreas in the splenorenal. Final point on splenectomy: OPSI, overwhelming post-splenectomy infection, particularly from encapsulated organisms. So patients must be vaccinated against pneumococcus, Haemophilus influenzae type B, and meningococcus, ideally at least 2 weeks preoperatively or as soon as possible post-op if emergency.
The esophagus is a muscular tube about 25 centimeters long, running from the cricoid cartilage at C6 to the cardia of the stomach at T11. 3 segments, each with its own supply and lymphatic drainage. Cervical, about 5 centimeters, supplied by the inferior thyroid artery, drains to deep cervical nodes. Wall is striated muscle. Thoracic, about 17 centimeters, supplied by bronchial and esophageal branches of the aorta, drains to mediastinal and celiac nodes. Muscle is mixed, striated above, smooth below. Abdominal, about 3 centimeters, supplied by the left gastric artery from the celiac, smooth muscle only. And this is the site of esophageal varices in portal hypertension, because the left gastric is the artery and the corresponding esophageal veins anastomose with the systemic azygous system, a portosystemic anastomosis. So, when an examiner asks the supply, segment your answer: cervical, thoracic, abdominal. 3 vessels, 3 lymph basins, 3 muscle types.
4 anatomical constrictions, each one a site where a swallowed foreign body or a tumor tends to lodge. Cricopharyngeus at C6, the upper esophageal sphincter. Aortic arch crossing at T4. Left main bronchus at T5 to T6. And the esophageal hiatus and LEOS at T10, the lower esophageal sphincter. Clinical disorders to know: achalasia, failure of LEOS relaxation, gives the classic bird beak appearance on a barium swallow. GORD, chronic reflux, can cause Barrett's metaplasia in the lower esophagus, a change from squamous to columnar epithelium, which is a precursor to adenocarcinoma in the lower third. Squamous cell carcinoma is found in the upper and middle thirds. Major risk factors are smoking and alcohol. And varices, those dilated submucosal veins at the portosystemic anastomosis between the left gastric and the esophageal veins. These are the ones that hemorrhage catastrophically in cirrhotic portal hypertension.
Two curvatures. The lesser curvature, the right border, carries the lesser omentum to the liver. The greater curvature, the left border, carries the greater omentum, the apron that hangs down over the small bowel. The regions cardia to outlet are cardia, fundus, body, antrum, pylorus. Arterial supply, and you can predict this if you know the celiac. Lesser curve, left gastric from the celiac and right gastric from the proper hepatic. Greater curve, left gastroepiploic from the splenic and right gastroepiploic from the gastroduodenal. Fundus, short gastric arteries from the splenic. 5 vessels, complete redundancy, which is why the stomach almost never gets ischemic. Venous drainage, into the portal vein directly or via the splenic vein and SMV. Lymphatic drainage to celiac nodes. And one critical clinical sign, Virchow's node, that's the left supraclavicular node. An enlarged Virchow's node is a classic sign of metastatic gastric carcinoma, also known as Troisier's sign. The duodenum is a C-shaped loop about 25 centimeters long, wrapped around the head of the pancreas, mostly retroperitoneal, except the first part. D1, the superior part, the duodenal cap, at L1. This is the only intraperitoneal portion, and it's the site of duodenal ulcers, particularly posterior ulcers, which can erode into the gastroduodenal artery sitting just behind. Classic exam scenario for upper GI hemorrhage. D2, the descending part, at L2. The ampulla of Vater opens here, at the major duodenal papilla. This is the foregut midgut watershed. Supply switches from the gastroduodenal above to the SMA below. D3, the horizontal part, at L3, crosses the aorta and IVC. The SMA passes anterior to it, the basis of SMA syndrome. D4, the ascending part, rises to L2 or L3 and turns at the duodenojejunal flexure, which is suspended by the ligament of Treitz, a useful surgical landmark for the start of the jejunum. The major duodenal papilla, the ampulla of Vater, sits on the medial wall of D2. It's the convergence point of the main pancreatic duct and the common bile duct, surrounded by the sphincter of Oddi. Critically, this is the foregut-midgut transition, both embryologically and clinically, because the blood supply switches here. Everything proximal to the papilla is foregut, everything distal is midgut. The minor papilla sits slightly proximal, and in some people, the accessory duct of Santorini opens there. Blood supply, and remember this as a watershed. Proximal to the papilla, foregut, supplied by the superior pancreatico-duodenal artery from the gastroduodenal, from the celiac. Distal to the papilla, midgut, supplied by the inferior pancreatico-duodenal artery from the SMA. These two anastomose around the head of the pancreas, the foregut, midgut watershed. Venous drainage parallels the arteries into the SMV and onward to the portal vein.
6 points to walk away with. Cantley's line, the functional divide of the liver, from gallbladder fossa to IVC. Caudate and quadrate are functionally left. Porta hepatis, 3 structures, CBD on the right, hepatic artery on the left, portal vein posterior. Calitz triangle, cystic duct, common hepatic duct, and inferior surface of the liver. Contents include the cystic artery. The 25-75 rule. Hepatic artery delivers 25%, portal vein delivers 75% of blood flow, but each contributes about 50% of the oxygen. Rule of odd numbers for the spleen, 1 by 3 by 5 inches, 7 ounces, ribs 9 to 11. Papilla of Vater, in D2, marks the foregut-midgut transition where the CBD and main pancreatic duct empty together. 6 high-yield facts. Burn 'em in.
So, that's part 2 done. In part 3, we finish the abdomen, appendix, diaphragm, abdominal wall, inguinal canal, hernias, and bladder. We'll cover McBurney's point, the biphasic pain of appendicitis, the 8-10-12 rule for diaphragmatic openings, the 3 flat muscles of the abdominal wall, MALT for the inguinal canal, Hesselbach's triangle, direct versus indirect hernias, and the layers traversed for a suprapubic catheter. If this has been useful, hit the subscribe button so you don't miss the final episode. Drop a comment if there's a Viva topic you'd like me to drill in detail, and check the video description for the link to buy the full MRCS OSCE preparation podcast when you're ready to go deeper. Thank you for watching, and I'll see you in part 3.